I come to one important point. No question that immune checkpoint inhibitors might be already looked at in the locally advanced disease, local therapies. Your thoughts, Riad?
So I know that we have a few clinical trials that we're trying to do in the spirit of sort of combination therapy. So we're really looking at that. Those are the results that we've seen that sort of have really sort of allowed you to sort of pass the barriers of, you know, expected response rates. We've seen that with some of the local therapies and sorafenib. We're hoping to see that with some of the immunotherapies, but we're clearly studying that, make sure the safety profile is there. And again, we want to keep moving that bar forward.
Great. So to summarize that part, no doubt that a lot is going on. As we heard, precision medicine in HCC is an evolving field, but really we don't have yet that understanding, especially in the distribution of the different risk factors and what they may allude to in regard to that genetic makeup of the tumors. In regard to what's really we're waiting for as data in the first line setting, lenvatinib obviously is the last bastion, if you want to call it that way, that we're waiting for the results of. In the second line setting, ramucirumab in the high FP level is still awaiting for. c-Met inhibitors, I have to admit, before the checkpoint inhibitors came on board, they were really like, you know, the aspire for, and I would say still we have to recognize them as such. And I would probably, you know, just while the advent of the immuno checkpoint inhibitors is ongoing, the c-Met inhibitors probably present like that back to the future kind of look, and we're waiting for the results of tivantinib and cabozantinib as well. And lastly, of course, with the checkpoint inhibitors, there's a lot going on in the field. It's mushrooming like beyond reality at this point in time, and this is again good news. We like that, and we're waiting for all the results of those studies to kind of better define any role they might play in regard to HCC. So with this said, this was a fascinating discussion with everybody, and this is extremely informative. And however, I'd like to really carry on some final thoughts. So we'll start with Dr. Finn.
I think one thing I would like to leave clinicians with is the fact that while in an academic center, multidisciplinary program, we're all interacting in a very coordinated way. But it's important in the community that clinicians stay engaged with their patients, specifically medical oncologists or hepatologists or gastroenterologists. Engage with the interventionalists. It's important that they be engaged in patients with early stage disease or intermediate disease so as to capture patients who can benefit from systemic treatment. There's now strong phase 3 studies in the front line with sorafenib, now in second line with regorafenib. And the only way we'll reach the true benefit that's been demonstrated in clinical studies with these molecules is to capture the patients that are eligible to receive them.
Fair enough. Thank you for saying that. And Dr. Kulik, your thoughts?
So I would say for patients who are in the community that if they have HCC, to have them be seen at least once in an academic center, because I think the target is moving as to who is a candidate for example, resection, some of the liver-directed therapy, specifically radioembolization, that may make somebody a candidate for resection, and even candidates for transplant. And we won't know that until they're seen and evaluated.
Absolutely. If I can comment on that, is that patients who are seen by the different disciplines have really shown an improvement in outcome, which is really very highly evidenced and published. Dr. Kelley, your thoughts?
I think that one of my key points to emphasize that this is really a disease on the move. Not only is the incidence dramatically on the rise and liver cancer reaching really enormous proportions worldwide as a second leading cause of death, that finally we're seeing momentum following along in drug development and huge amount of interest in finding new therapies and a promise from many of these therapies to make a difference. So to not give up on this population and to make sure, like I echo completely what Laura said, to refer patients to an academic center at least once to make sure that there aren't new therapies popping up along the way, whether they're liver-directed, surgical, interventional radiology, or we hope systemic, that can make a big difference down the road.
A beautiful message of hope, of course, and especially for our patients and loved ones. And Dr. Salem?
Yeah, I mean, I would say HCC is it's clearly a very dynamic field. It's a very exciting field. As an interventional radiologist, it is my favorite sort of disease entity to work with. It allows me to interact with experts like yourselves from oncology, hepatology, and it's really something that is extremely fulfilling from my aspect. You have to know the literature. These are things it's so dynamic from the discussions that you moderated today, Ghassan. It's so dynamic. It's all sorts of new things that are going on. So I would say be knowledgeable about the literature, engage all of the disciplines. You'll maximize outcomes. But again, I think the future is very bright. And again, it's a very, very exciting field to be part of. I'm certainly proud of that. But I would encourage people to really engage quite a bit.
Great. Well, thank you all for your contributions for this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.